So I would thank all the speakers for their nice overviews, but I'm very worried now. Because Mauro and also Ronan, I didn't hear the word physical therapy at all. Not in relation with your surgery, not as a clinician, how to deal with this when those patients with all these kinds of prolapses enter your office. So I'm a little bit worried because you are not using it, while Gary, most likely with 10 randomized clinical trials, showed that physical therapy has a role. So where is the heck the physical therapy here in your practice in Rome and in Dublin?
No, we can talk from here.
Mauro,
we can talk from here.
It's better from there.
While you're coming back, I mean, I was asked to talk about surgery for rectocele, which is what I talked about. Yes, of course, we work closely with physiotherapists in the pelvic floor center. With regard to obstructive defecation, the primary role that we have is in dealing with anismus and trying to get biofeedback to relax the outlet and relax the hiatus. But yes, I mean, I've been engaged in 3 randomized prospective trials in relation to postpartum physiotherapy to try and restore the pelvic floor. So yes, we use it all the time, but it doesn't fix obstructive defecation except in the context of anismus.
And what about Rome?
Yeah, you focus exactly in which is one of the weak point of every honest surgeon on dealing with pelvic organ prolapse. If I would like to answer your question, if you can put my last slide that I couldn't present before, and I leave it. It's possible? My presentation, Cervini.
No.
No.
The other one, Savigny.
The other one.
Savigny.
Yeah, the role of the physiotherapy is absolutely a pivotal role. Yes, go forward. Go.
Last one.
At the end. Go.
Final one.
Fine. Go. Yes. Forward. Okay, and go.
You see how complicated physical therapy is in Rome.
The problem is that I would like to show. Go. Continue until the end of the presentation. Thank you.
Yeah.
Go. Again. Continue. Lot of slides, please. Go. Fast. Yes. Again.
The last
again.
slide.
The last. Again. Sorry for this time, but it's important. Again. Quite arriving. Yes. Again. Go. Sorry, but it's important. It's very impressive. Yes, that's it. Back.
One back.
Yes.
Yeah.
This is published last year in Neurourology Urodynamics. Does pelvic floor muscle training augment the effect of surgery in women with pelvic organ prolapse? A systematic review of randomized controlled trials. And the conclusion from the authors, the evidence did not sufficiently support aiding perioperative pelvic floor muscle training to surgery over the use of surgery alone to treat prolapse in women undergoing surgery. This is the answer to your question, but it's not a provocative. I think that you are right, absolutely right, but as a surgeon, we have the mentality just to, honestly, I need to answer honestly, to approach the patient because very often in a referral center like us, we see they arrive a disaster from an anatomical point of view, and so the objective is to treat the patient in the second stage after the 3 to 6 months later on.
So when I see this, actually what it says to me, and that is what is written, it does not sufficiently support, means that actually the proof is not yet there because of lack of studies maybe, or is it the lack of success rate in those studies that have been done? So what message would we take from this?
Systematic review. Systematic
yes,
review.
I know it is systematic, but yes, Kari, for sure.
Because I presented 2 studies. There are very few studies that has been done in connection with the surgery. So this systematic review is based on very few studies, and it's also including studies that are not randomized controlled trials, and we should try to avoid that. The point is that you are correct. There is no evidence for that we should have a combination of surgery and pelvic floor muscle training so far. We can discuss the content of these interventions, as they may not be really ideal interventions. But I think the main thing is that as surgeons, you think, what sort of surgery can I do for this patient? While we should think, what sort of treatment should this patient have? And maybe in your department, you get those who are really above that, far from that stage that they could have physiotherapy. I don't know. If you have really the stage 4, then we couldn't have it. But this is something else. This is because the trials I was referring to, they are doing pelvic floor muscle training as the primary thing, and then it's showing effects. So they should have the trial of pelvic floor muscle training before they enter surgery. And I think you agree on that.
As a surgeon, I think also Ronan, we agree with me. I would like to ask to you, as a great expert, what do you suggest for the physiotherapy? Because I think that actually there is absolutely a place for a patient to be treated. But before or after the procedure, what do you suggest? What do you think?
They should have the option of having pelvic floor muscle training instead of surgery, because it can also be watchful waiting for some years. So if you have a stage 1, 2, or even 3, you should try with physiotherapy first before surgery. That's the evidence that we have. We have no evidence, as you said, in combination with surgery, although we need much more trials in that area. So they should have the option, instead of putting mesh into women, giving devastating, horrible problems for the rest of their lives, they should have the option of something that is not giving any complications at all.
What I would suggest is that, especially in those fine and fantastic pelvic floor centers, like you are leading one, that we should try to have physical therapy in such a way that it is a real program that could help, that we would have assessed the elements of that program, and then together that we would try to find that we would end up with not sufficiently support, but with sufficient support that it is working or that it is not working, because this conclusion only says that there is not enough done in that field. And I think it's, for the patient's merit, very important that we are going to, in a multidisciplinary way, construct the assessment and the pelvic floor muscle training in such a way that we have these answers in one of the coming ICS annual meetings. And I think that is fair to the women with pelvic organ prolapse. And I have another question for you, for all of you. I think when we see that there is already long-standing evidence about the procedures for pelvic organ prolapse, and still we see so many patients having recurrence of problems, what is then the patient selection? A, to do the surgery, that in the first place, and B, in which patients we should avoid, where we can have predictive factors that they will have relapses.
Well, the fact that a percentage of patients have relapses doesn't mean that you should stop doing the procedure. I mean, if you have an informed consent, and actually, when we're dealing with functional disorders, which we're dealing with now, consent is a very difficult process. It requires that it is truly informed consent, and I would teach our medical students that we're not actually looking for consent, we're looking for a request, so that the lady herself knows what the options are, including physical therapy or adjunctive physical therapy. It should be made with multidisciplinary input. and that it is her choice as to what option she takes, and aware that the outcomes are 70 to 80% satisfaction, but not 100% satisfaction. Mm-hmm. But that doesn't mean you shouldn't do it, as long as it is done technically well. Then the majority of patients have a reasonable outcome.
Now, for both of the surgeons, you have for sure many residents for training for surgery. Would it be fair to say that you would include also a very well-trained physical therapist, also related to trying to define which patients should go for the physical therapy and how to follow up with this, seeing whether we could avoid the surgeries as such? Because I think the physical therapist needs your expertise and your excellent way of looking to the diagnostics of those patients, and would help to construct the programs that would really be feasible. What do you think about such a concept?
I think you are completely right, but before to change the fact of the life, it needs to change the mind of surgeon, of doctors, because obviously the physiotherapist and the surgeon should cooperate together for the well-being of the patient. But very often there is a complete, if you look at the meetings, there is a straightforward to the surgery without taking care sometimes about what is the quality of life, even though now is emerging the pivotal role of the quality of life, because I can cure anatomically a patient, but with the border symptom that can render the procedure absolutely a disaster for her. So I completely agree with you that in the near future, center of excellence or third level center, they should have a combined vision of the patient, discussing together, surgeon as well as physiotherapy, the common approach with the patient.
We'd like to invite all the people in the audience to comment or to enter into the debate, because that is very important, I think, because I would like to hear your experience and also the challenging questions for our panel.
Thank you very much, firstly, for the wonderful discussion roundtable. I'm Meni Alkalai, gynecologist from Israel. I have a question to Professor Ronen. It was amazing for me to see this kind of incline in laparoscopic rectopexy, which is very comparable to the laparoscopic sacrocolpopexy that we are seeing as gynecologists in our field. I would like to ask you, what about the cases that you have obstructive defecation, rectocell, and also central compartment, uterine prolapse? Is there a place to combine these kind of approaches, the rectopexy and the sacrocolpopexy?
We do it all the time. I'm fortunate in that I work with, we have a pelvic floor clinic, and we have a urogynecologist, we have a physiotherapist, we have a nurse, and we have a coloproctologist who can assess the patient all in the one visit, and we frequently operate together. So yes, where there is anterior compartment, we do a combined operation.
I'm not talking about anterior compartment. I'm talking about central compartment.
Well, and likewise central compartment.
Yeah, because sometimes if you're doing rectopexy and the attachments are very near to the same attachments that we are doing on the anterior rectal wall, we are doing in the posterior vaginal wall, but while it adheres, it's more or less the same place.
A ventral rectopexy is almost the same operation.
Yeah, so it might correct very well also central prolapse as well.
Yes, it does.
Okay.
The problem is that it doesn't always correct all of the symptoms that the lady has, because you deal with one component of the pelvic floor. Absolutely. And the others become manifest.
Okay, thank you so much.
May I answer to Meni, my friend Meni? We do, in case of rectal prolapse, we do ventral rectopexy, and we fix the apex of the vagina or the uterus,
cervix.
Both mesh
to
the sacrum.
Yeah.
Two meshes.
So inserting two meshes in the rectovaginal septum?
Absolutely.
Two layers of mesh? Sir.
Yeah.
Okay, thank you.
So next question at the right, for me at the right. So you? Yes?
Ewelina Malanowska from Department of Gynecology, Poland. I have a question to Professor Mauro Salvini. What is your opinion about laparoscopic lateral suspension developed by Gernard Dubuisson from Genève? Because we all know that sacrocolpopexy is quite a challenging operation when you're operating in the abdominal area where are intestines. And what is your opinion? And after 1 year of sacrocolpopexy, there are many studies that we have recurrence of anterior wall prolapse. So,
yes, I would like to thank you for your question. I didn't mention in my presentation because the data are very few, but is a new proposal for the abdominal suspension in case of severe prolapse. Not anchoring to the sacrum, but just anchoring lateral, just recreating kind of cardinal ligament attachment. And the preliminary results look like promising, and I think it would be an option. The only problem to be aware is that there is a possibility, because there is a verticalization of the axis of the vagina, that then developed a rectocele or a severe enterocele. This is the main concern, but in other way, I think it's probably one of the possible options in the future.
Go on.
Another question?
Very short, because there are other people also want.
Who of all of you measured the quality of life after surgery in your departments? The quality of life measured by validated questionnaires. We all know sexual activity or effectiveness of operation. PFDI, IQS.
Yeah, the classical one. Yeah.
Do you all measure this quality of life?
Absolutely, yes. We use the classical questionnaire, quality of life, as well as the questionnaire about the obstructed defecation or the symptoms of anterior compartment.
Well, I think that's a very important point, because we should be looking at patient-reported outcome measures all the time, because we're dealing with a functional disorder and we're trying to improve quality of life through improving the function, and you're absolutely right.
Thank you.
Then to the left, please. Yeah.
Ulla Hansen, Denmark. I have a comment and a question, quick. In our practice, we do talk a lot to the women and to obtain informed consent, and quite a few of them abstain from surgery when they hear that they can probably not fit a pessary after surgery if a recurrence occurs. So I think that's an important point to think about. And then I'd like to ask Professor Berg, in the study conducted by Brecken from 2010, were you able to see any morphological changes on the side that had the avulsion, if you could divide patients into patients having avulsions and patients not having avulsions?
We did not look at avulsions in that study, so we can't say.
Just general POP patients?
Yeah, well, no, yeah, there were no, we did not classify on avulsions. We have done that postpartum in the last study we published, but not in that one. So we don't have any data on avulsions.
Okay, thank you.
Next question, then the last.
Kato from Nagoya, Japan. Well, you said no symptoms, no surgery. I generally agree. However, well, now we have many frail elderly with dementia. They don't recognize their condition at all, but severe hydronephrosis and recurrent urinary tract infection, and the vagina and uterus are contaminated with stool, and caregivers and family are very anxious. Well, in that cases, we can do operation, don't we?
Absolutely agree. I said that no symptoms, no surgery, but obviously in case of severe hydronephrosis, or in case of interfere with the upper urinary tract, it's mandatory. Obviously related to the general condition, but I agree absolutely with you that the patient should be operated.
Thank you.
So before I go back to you, Kari, I want to ask you a question. What a kind of patient the physical therapist would, with this kind of pelvic organ prolapse, would he or she like to see And I mentioned this related to severity, because we try to find out how well we can help a patient. Or would you say, send every patient with this kind of problem to us?
For the moment, I don't think we have any data that are specific enough for that, because if you look at all these trials, they cannot separate between stage 1, 2, and 3, because there will be so few patients in these groups. So it's very hard to say. So for the moment, I would say that everyone should have a try, because there are no complications. That's why they could try this first, and we have evidence that it may help.
I ask this because, for sure, also the audience, the surgeons, they have not that answer, but they have to choose, together with the woman, whether they should counsel the women to come to us, yes or no. And that's why my question is like this. And could you speculate on it, or can't you not do that?
Well, the speculation was that I think everyone should have an option, because it doesn't make any negative things before surgery. They can still have a surgery, and they can still have a pessary. And we have not been talking a lot about pessary, although the evidence for pessary is not that strong, but it is an option that has not been used enough, in my opinion.
So
I have been seeing a patient who was in a study with us, and she was just trying this because we were looking at the peripheral muscle function, and she had not this option. She was on the waiting list for surgery, and she walked out like a new person because she had a pessary inside. That really made me think that we are using this really too seldom as what we could.
Even stage 3, POP-Q, we are going to try.
Yes, because in the trials, we have had stage 2 and stage 3. So, it's yours.
That's my telephone.
And we can't tell, because there are too few in each group. But we have evidence that we have also lifted from 3 to 2.
Yeah. Okay. Thank you very much. Last quick question in the middle.
I have a comment similar to your comment about the physiotherapy, because we all, as the surgeons, know how look third and fourth, even second degree of the prolapse. We have to fulfill patients' expectations. So when the female patients come to our office and say, I have bulge in the vagina, and do something with it now, and she doesn't want to extend her time with physiotherapy, so we have to think about it, what are the patient's expectations, and we are facing with this in our office, and sometimes it's not so easy to tell the patient, 36 years old patient, for example, with third stage, to do the physiotherapy if she wants to have an effect now.
Thank you for that comment. You cannot comment on that. I'm sorry, the time is over. I would like to thank the excellent speakers for their contribution, and you all for your participation and being here, and also for the discussion that we had. Thank you very much, and I wish you a very nice evening tonight. Thank you.